In the next section, we'll be looking at the neuromuscular physiology of the gastrointestinal tract. In this section of the GI physiology module, we'll be looking at the neuromuscular physiology of the GI tract. Before we proceed, it's important to know the layers of the GI tract. It may be tedious, but this section is made much easier by remembering the different layers that are present. Namely, from the inside out, we have the mucosa, the muscularis mucosa, the submucosal plexus, or the Meissner's plexus, the submucosa, the circular muscle, the myenteric plexus, otherwise known as Auerbach's plexus, the longitudinal muscle, and finally serosa. This is shown again in the next slide with the presence of lymph nodes, which are also lining the GI tract. The innervation of the GI tract, unsurprisingly, is parasympathetic and sympathetic. However, there is also intrinsic innervation, which receives both sympathetic and parasympathetic innervation. So with the parasympathetic, it's innervated by the vagus nerve, which is a mixed nerve. 75% is afferent, 25% is efferent, and therefore in the GI tract we have the vagovagal reflex, where the afferent and efferent fibers come into play. The sympathetic ganglion are represented by the celiac ganglion, the superior mesenteric ganglion, the inferior mesenteric ganglion, and the hypogastric ganglion. Intrinsic innervation that I already mentioned receive both sympathetic and parasympathetic fibers. They can direct all functions of the GI tract in the absence of extrinsic innervation. Therefore, looking at the next slide, the intrinsic nervous system basically can communicate with both the parasympathetic and the sympathetic systems. As is shown in the middle of the slide, the intrinsic nervous system is present in the submucosal plexus and the myenteric plexus. They can communicate with each other and communicate with the parasympathetic and sympathetic systems. The intrinsic or enteric nervous system has plexuses which consist of nerve bodies, axons, dendrites, and nerve endings. They direct contractile, secretory, and endocrine functions of the GI tract. Therefore, as has been explained earlier, they are capable of directing all functions of the GI tract. The pathways can be multisynaptic, as shown in the previous diagram, and integration of these activities can occur entirely within this intrinsic nervous system. Therefore, signals can flow in multiple directions between the submucosal plexus and the myenteric plexus, and along the plexus in different directions. Neurons may also release more than one neuroactive substance in response to stimulation. This also helps to explain why this can be a system which directs all functions of the GI tract. The neurotransmitters and neuromodulators which are present in the intrinsic nervous system are numerous. We will go through them briefly here. Acetylcholine and norepinephrine unsurprisingly play a large role in this system. Acetylcholine causes the contraction of smooth muscle in the wall, causes the relaxation of sphincters, and increases salivary, gastric, and pancreatic secretion. An easy way of remembering this is that if the sphincters are contracted when contraction of smooth muscle is taking place, it would cause pain. Therefore, along with contraction of smooth muscles, the sphincters have to relax so that GI contents can move smoothly along the tract. Norepinephrine causes relaxation of smooth muscles and contraction of sphincters. Therefore, it acts in opposition to what acetylcholine does. It also increases salivary secretion. This is one thing it has in common with acetylcholine, which, as we already mentioned, increases secretion along all parts of the GI tract, namely salivary, gastric, as well as pancreatic. Vasoactive intestinal peptide causes relaxation of smooth muscle and increases intestinal secretion, therefore acting in ways that acetylcholine and norepinephrine both do. The way I try and remember this is that VIP combines the actions of acetylcholine and norepinephrine. Gastrin-releasing peptide, or GRP, increases gastrin secretion, and we have discussed this in detail already. Substance P causes contraction of the smooth muscle and increases salivary secretion. Enkephalin, as was previously mentioned, causes contraction of the smooth muscle and decreases intestinal secretion. Neuropeptide Y causes relaxation of smooth muscle and decreases intestinal secretion. Therefore, neuropeptide Y and enkephalin work in opposition, where enkephalin works to contract smooth muscle, but neuropeptide Y works to relax smooth muscle, but they both decrease intestinal secretion. There is no easy way of remembering what each one of these neuromodulators in the nervous system does, except to sit down and remember them. I think the two easiest ones to remember are acetylcholine and norepinephrine, because they act in opposition to each other and they play such a large role in the GI tract. In the next diagram, we have an overview of the extrinsic innervation of the GI tract. As I mentioned earlier, the enteric nervous system is capable of directing all functions of the GI tract, and pathways are multisynaptic, with integration of activities occurring in the system. This is displayed on the left side of the screen as you look at it, where ganglia that are present in the myenteric plexus and the submucous plexus are capable of communicating with each other. In the same way, we have ganglia with a norepinephrine as the primary neurotransmitter, which again are capable of communicating with each other, showing that these pathways are multisynaptic and information can flow in multiple different directions. We will now discuss the other two pathways, namely the parasympathetic and the sympathetic system, which play a role in extrinsic innervation. The parasympathetic pathways are preganglionic and arise from cell bodies within the medulla. They consist of they travel in the vagus nerve up to and including the ascending colon. The vagus nerve carries afferents and efferents, as we discussed earlier, and hence we have the presence of a vasovagal reflex. Sacral output from S2 to S4 occurs via the pelvic nerves. Preganglionic nerves synapse in the submucosal and myenteric plexus. This is shown in the previous diagram, where on the left-hand side of the screen, parasympathetic ganglionic nerves synapse in the myenteric and submucosal plexuses. Postganglionic nerves release acetylcholine or other peptides that we've already discussed, such as VIP, substance P, or others. Parasympathetic activity generally increases the activity of intestinal smooth muscle. Sympathetic innervation is from T1 to L3. This is postganglionic, with presynaptic neurons synapsing in the celiac, superior mesenteric, inferior mesenteric, and hypogastric ganglions. Nerve fibers carry both afferent and efferent signals, and sympathetic adrenergic activity generally decreases activity of the intestinal smooth muscle, in contrast to parasympathetic innervation, which increases activity of the intestinal smooth muscle. So if you look at the overview diagram, on the right-hand side as you look at the screen, at the bottom of the screen we see the presynaptic sympathetic ganglion, and then the postsynaptic fibers, which can synapse, for example, in the myenteric plexus. From there, in the myenteric plexus, you can have signaling taking place mediated by norepinephrine, with further synapses in the submucosal plexus. GI blood flow is very, very important clinically, because any lack of blood flow can cause intense pain. This is manifest clinically by pain which is out of all proportion to symptoms. Therefore, patients who will seemingly be sitting there in great comfort will start screaming in agony as soon as you touch their abdomen. This is because they have got ischemia of the gut, and this is caused by a number of different factors such as atherosclerosis, thromboembolism, or in vascular disorders such as SLE. Gastrointestinal blood vessels form part of the splanchnic circulation, and food elicits an active hyperemia, i.e. the amount of blood going to the GI tract is increased. Sympathetic nerve activity can greatly decrease intestinal blood flow and venous volume. And a vasoconstrictive mechanism provides 200 to 300 ml of blood in the setting of shock. Therefore, when vasoconstriction takes place in a patient who has been shocked or has been started on vasoactive agents such as norepinephrine or phenylephrine, blood flow is decreased, and one of the things to watch out for is gut ischemia, as blood flow to the GI tract is impaired. So, as we've discussed throughout this GI module, all GI activity is occurring in different phases, but these phases are intermixed. So we will looking at the cephalic phase, the gastric phase, and the intestinal phase. As we've discussed, the cephalic phase begins with the sight, the smell, the taste, and the thought of food. However, it's important to remember that during this phase, the gastric phase will already have begun, where gastrin secretion may be stimulated by this. The duration of the cephalic phase is short, is directed from the CNS by preganglionic fibers in the vagus nerve, which synapse in the myenteric plexus. Postganglionic parasympathetic nerve fibers, which innervate the parietal cells, chief cells, mucous cells, and G cells, also play an important role. Now, all of these cells that we've just mentioned are present in the stomach, but they'll be stimulated during the cephalic phase. Therefore, all of these actions are occurring at once. Emotional states can also exaggerate or inhibit the cephalic phase. So anger, hostility, stress can either act to increase or decrease secretion. With the gastric phase, formally begins with the arrival of food in the stomach, but again I want you to remember, all of these phases may be occurring all at once. Formally, the gastric phase begins when food arrives in the stomach, and by the arrival of food, this phase is potentiated. The stimulation of the stretch receptors in the stomach wall, the chemoreceptors in the mucosa will trigger reflexes coordinated in the myenteric plexus, and neurons involved in reflexes are the same as that mediate the cephalic phase. Again, outlining that these things will occur in unison throughout the tract. There's increased motility and initiation of mixing waves in the gastric phase. What this means is that food contents are essentially churned around in the stomach, and the idea is that homogenization takes place and acidification takes place of these digested food contents known as chyme. There's increased acid and pepsinogen production, and protein digestion is initiated when pepsinogen is activated to pepsin by the low pH in the stomach. The duration of the gastric phase is normally 3 to 4 hours. GI motility is characterized by different types of waves. The slow wave, which is present, is not characterized by action potentials, but oscillating depolarizations and repolarizations. The frequency varies along the GI tract and can be as few as 3 in the stomach to 12 in the duodenum per minute. They originate in the intestinal cells of Cajal in the myenteric plexus. These cells essentially act as a pacemaker in the myenteric plexus, resulting in initiation of these slow waves. We also have the presence of spike potentials, which are actually true action potentials, unlike the slow wave. They occur automatically when the resting membrane potential becomes more positive than about negative 40 millivolts. The normal resting potential is between minus 50 and minus 60 millivolts. Calcium ion influx is responsible for action potentials as in other parts of the body, and as with initiation of most action potentials in the body. Stretching of muscle, stimulation by acetylcholine, and by parasympathetic fibers, nerve fibers that secrete acetylcholine, result in depolarization and result in the generation of an actin potential. This also helps to explain why the parasympathetic nervous system is associated with increased intestinal smooth muscle activity. Factors that cause hyperpolarization are norepinephrine or epinephrine, and sympathetic nerves that secrete norepinephrine, again outlining why the sympathetic nerve fibers are associated with decreased activity. This is one way of trying to bring the physiology together with what we see physically, i.e. the parasympathetic nervous system secretes acetylcholine. This stimulates stimulates depolarization, and therefore we have increased smooth muscle activity. When hyperpolarization takes place, depolarization is therefore inhibited, and there is decreased smooth muscle activity. This next diagram is an overview of what we've just discussed and forms a nice list. Stimulation is precipitated by stretch, acetylcholine, and parasympathetic nerve fibers releasing acetylcholine, resulting in depolarization and these spikes. And resting or hyperpolarization is stimulated by norepinephrine and sympathetic nerve fibers that often will secrete norepinephrine as well. Mixing movements are present throughout the GI tract. They are otherwise known as segmental contractions, and they occur every few centimeters in the gut wall and are stimulated by motilin. Contractions just last for a few seconds, and new constrictions occur at other points in the gut. What happens with mixing waves is that with peristaltic waves we can generate most of the mixing that needs to occur if forward progress is blocked by a sphincter. For example, in the GI tract, you can have forward progress occurring, but because there is a closed sphincter, mixing can occur in the stomach. In other parts of the GI tract, there is no sphincter present, and so these movements need to be modified for mixing to take place. From a diagrammatic perspective, the way to visualize this is that in individual parts of the GI tract, peristalsis will cause forward movement of food contents. With the presence of the mixing wave, you have a few short centimeters where food is essentially being churned around so that mixing can take place. Peristaltic movements or propulsive movements are basic movements in the GI tract that occur from the esophagus all the way down to the large bowel and occur in all parts of the GI tract. The stretch initiates a circular contraction behind the stimulus and an area of relaxation in front. Again, this is very important to remember, because if this is inhibited for any reason, if contraction occurs with an area where there's contraction in front of the area of contraction, this results in the generation of pain. The propulsion rate varies from 2 to 25 centimeters per second, and activity can be increased or decreased by autonomic input. When the myenteric plexus is absent, this activity may not occur at all or can occur weakly. This diagram is looking at an overview of segmental and peristaltic movements. The top three figures show segmental contraction, where food is moving forward, and as I described to you earlier, for a few short centimeters, contraction is taking place, mediated by motilin, and food is essentially mixed together in a small area of the gut, and then peristalsis can take over. What happens with peristalsis is there's an area of contraction behind a wave and an area of relaxation in front, resulting in propulsion of food forward, as shown in figure B, diagrams 2 and 3. The migrating motor or myoelectric complexes, which we referred to briefly earlier, occur many hours after a meal or during the interdigestive or fasting state. Their activity recurs approximately 90 to 100 minutes and they begin in the mid portion of the stomach and spread all the way through the small bowel to the ileum. These are moderately active peristaltic waves and essentially act as a cleanup system in the GI tract. They sweep excessive digestive secretions which haven't been carried forward by peristalsis and take up other intestinal residue and sweep it into the terminal ileum and then on into the colon. Eating immediately abolishes this motility because then peristalsis, which is the forward propulsive movement of the GI tract, will then take place, and there's no need for the migrating myelectric complex at that time. And in fact, they can be unnecessary at the time of peristalsis. Next, we'll discuss gastric mixing and emptying. As we've outlined earlier, the lower body and antrum of the stomach are very muscular. Peristalsis waves start in the mid-stomach and move towards the pylorus. The pylorus acts as a block, as food cannot go through the pylorus, and it closes as the wave approaches, causing food to come back or retropulsion of stomach contents. During this mixing process, chyme is what's generated. This is viscous, highly acid, partially digested food in the stomach. Parasympathetic stimulation, gastrin and motilin increase the force of these forward waves but do not affect the frequency of the waves. Food stomach contents will then be released slowly in a controlled way from the stomach into the duodenum and can be controlled by hormones such as secretin. Surprisingly, sympathetic stimulation, secretin and GIP decrease the force but not the frequency of the wave. Gastric emptying takes about 3 to 4 hours. Liquids are emptied earliest, and this again makes sense because this allows for increased mixing of more solid particles. Particles which enter the duodenum are less than 1 cubic millimeter. Fat stimulates cholecystokinin secretion from the eye cells in the duodenum and jejunum, and this slows gastric emptying further. Between meals, contractions occur known as the migrating motor complexes or myelectric complexes, which act as a cleanup system for the intestine and are stimulated by motilin. In this section, we looked at the neuromuscular physiology of the GI tract. It's important to understand the innervation of the GI tract, as well as the pivotal role played by neurotransmitters in the parasympathetic, sympathetic, and enteric nervous systems.